Thanks, John. Good morning, everybody. My name is Sara Dugan. I am a psychiatric pharmacist and faculty at Neomed. And oh, got jumped on here. I'll be presenting today. Our didactic topic is the last of our drug interaction topics. And today we're going to focus on medications that are used for the treatment of tobacco use disorder. Objectives, we're going to look at the prevalence of tobacco use in the United States, list the drug interactions that are associated with meds that we can use to treat tobacco use disorder, and describe some strategies for managing patients who may experience some of those drug interactions. Just full disclosure, as I had started this, all of the other ones, so drug interactions with opioid use disorder, fairly discrete. Drug interactions with alcohol use disorder, also fairly discrete. I went to do this one, not categorized quite the same way. So there's a lot of information about tobacco use, about nicotine dependence, and then tobacco use disorder kind of is a little bit different. So you will see, I think, all three terms pop up, just because from a literature perspective, we're a little bit more broad in this particular category than what I was anticipating. Just a quick reminder, our focus is going to be on drug interactions. So drug interactions being a reaction between two or more drugs. I'm also going to include food and beverages, especially for the nicotine replacement products, that may result in a medication being more or less effective. So we may see a greater exposure to that particular medication, or we may see lower concentrations than what we were anticipating. And that may be a result of two different types of interactions. So pharmacodynamic interactions, so the way that the medications work, or pharmacokinetic interactions, so the way that the body processes the medication may be different. And we will actually see both of them for most of the medications that we'll talk about later. So I wanted to start just looking at tobacco use. So I feel like this is one of the areas where there's a lot of attention on nicotine dependence and tobacco cessation, and then maybe it falls off a little bit in favor of something else. But I was a little bit surprised that the numbers have remained relatively consistent. So in looking at some of the national data, the National Health Interview Survey, so this is a yearly survey. It's one of the longest national surveys that's conducted. It was originally conducted in 1957, and it's been done so pretty consistently throughout. But its intention is to monitor health of adults in the United States. They target over 27,000 adults, and they want to do confidential face-to-face interviews of civilians, so individuals that are outpatient, capturing information both on adults as well as children, so families that may all live together. And they're looking for just general information, injury, illness, accidents, chronic conditions, health behaviors, activities of daily living, healthcare access, insurance. And part of what they do capture is substance use. So looking at some of the substances that individuals use. So the data that's available from 2021 found that there were more than 46 million adults in the United States that were using tobacco products. So of those tobacco products, the combustible ones were found to be the most prominent. So this included traditional cigarettes, cigars, and pipes. So 77.5% of the respondents were using some type of combustible product. Of the combustible products, cigarettes are still the leading product that's being used. But when they looked beyond just the combustible products, there was a pretty significant portion of people who are using multiple types of nicotine products. So they may be using cigarettes. They may also be using some of the pouches. They may be using electronic cigarettes as well, which don't show up in the combustible because they're not technically burning. So there really looks to be a little bit more of a mix, even though the cigarettes still lead the way. When they looked at prevalence of individuals who are using tobacco products, cigarettes were still almost 3 times more likely to be used than electronic cigarettes. It depends on the cohort. So in some of the younger cohorts, older teenagers, young 20-year-olds, the difference is much smaller. For some of the older adults, that difference is still relatively maintained. So there definitely looks like there's a shift, but it's still pretty consistent use. The National Survey on Drug Use and that's the wrong number that's on there. The National Survey on Drug Use and Health is another national survey that's done. It's administered by the Substance Use and Mental Health Services Administration. So this survey went out to more than 67,000 individuals, also in person, again, collecting information. This one's a little bit more focused on a number of different substances, tobacco being one of them. Tobacco use in individuals, so this was a bigger portion. For the National Health interview, they were looking only at adults that were 18 and older. For this survey, they were looking at individuals who are 12 and older, and that should be 49.9 million. So it was about 3.9 million more when they included those that were 12 to 17. So there still is a significant portion of individuals who are adolescents that are starting to use tobacco type products. I thought then, because the National Survey on Drug Use and Health for many of the prior versions has pretty well broken out data on use disorder. The most recent one from 2023 did not include tobacco use disorder. They just used tobacco use. So I was able to find some information on tobacco, on nicotine dependence. And then the most recent information on tobacco use disorder was from 2021. So nicotine dependence was projected to occur in about just under 10%, so 8.5% of individuals who were 12 and older within the last 30 days. So individuals who noted withdrawal effects because they were consistently using nicotine type products. Now, this does not necessarily mean it fits tobacco use disorder criteria, but those may be individuals who would be candidates for use if they are trying to cease their tobacco product use. For tobacco use disorder, that occurred in approximately 10% of patients who were using daily tobacco products. For those that were using non-daily products, the percentage was much smaller. It was between 4 and 6% met criteria for tobacco use disorder, but still with at least 46 million being our denominator, that's a pretty significant portion of patients. So there still are a large number of individuals who could benefit from the use of an assistance product to help them no longer use their nicotine products. So why would it be beneficial for them not to use tobacco? So just kind of as a reminder briefly, so decreases the risk for cancer. It's been directly correlated to at least 12 different types of cancer, things like AML, bladder cancer, liver cancer, cervical cancer, colorectal, esophageal, kidney, liver, mouth, throat, pancreas, stomach, and larynx. It can increase life expectancy. We see lower risk of cardiovascular disease. There's a number of different cardiovascular factors that have been demonstrated to be lowered starting relatively quickly after an individual ceases the use of tobacco products. It can lower the risk of the development or progression of chronic obstructive pulmonary disease. It can lower the risk for reproductive complications, specifically looking at low birth weight and preterm labor. And it can reduce overall inflammation, which may be involved in a number of other disease processes. So recognizing the health benefits, continuing to have the discussion about tobacco cessation can be beneficial, and recognizing that not everybody can stop without some additional assistance. So we do have 3 categories of medications that can be used to assist those patients with tobacco cessation. So bupropion, I lumped all of the nicotine replacement products together, and varenicline. So looking at these particular agents, are they actually helpful? Yes. So if we're going to say that they could potentially be used to increase cessation, how much of a difference might that make? So I tried to pull as broad a efficacy rating as possible for each of these. So for both bupropion and the nicotine replacement products, they came from a Cochrane database review. So for bupropion, the relative risk of a successful quit attempt versus no treatment was 1.6. For nicotine replacement therapy, they found an enhanced rate of successful quit attempts was increased by 50 to 60% compared to abstinence only. So individuals that were not necessarily engaging in treatment, that was just the way they described it. And then for varenicline, the relative risk of continuous abstinence, which was defined as at least 3 months of abstinence, was 4.6 compared to placebo. So we do see across the board, they all can be helpful. This was monotherapy. There are some higher rates of efficacy in looking at some combinations of these products. But since we're looking at drug interactions, I wanted to include just the efficacy of them as monotherapy. So they can work, they can be beneficial. There is justification for why we'd want to use them. So let's look at some considerations related to that. So for bupropion, this is one of the products that can be started about a week before the quit date. Doses can be titrated. Therapy can be continued for at least 12 weeks, and it can be used alone or in combination. So this should give a patient about a week to be able to get to steady state, to adjust to any adverse effects that they experience when they start taking this medication before they actually stop using any type of nicotine product. Pharmacokinetically, it tends to be rapidly absorbed. It is protein bound, but for the most part, it's going to get where we need it to. But the bigger problems we're going to have are related to the metabolism. So it is processed using the cytochrome P450 enzyme system relatively significantly. Cytochrome P450 2B6 is the main enzyme that processes it, but it is minorly metabolized by a number of other enzymes, as you can see listed there. Recognizing that, I did not include, for full disclosure, I did not include agents that can either induce or inhibit those other enzyme systems. I did try to pull specific articles looking at if you're using this in combination with something that would be an inducer or an inhibitor. Clozapine, olanzapine, I'm looking at you. They really didn't see a difference in terms of adverse effects or changes in efficacy that have been reported with those other agents. So the 2B6 appears to be the main driver for metabolism, although I do just want to point out there may be other changes that you can see if patients are on pretty potent inducers or inhibitors of some of these other enzymes. So from an interaction standpoint, what is it that we've seen? So pharmacokinetically, bupropion is a 2D6 inhibitor. So it can block the actions of this enzyme fairly significantly. That would result in higher concentrations of medications that are processed using the 2D6 enzyme. There are quite a few of them. I listed just a handful here for you to take a look at. And we would see potentially some additional adverse effects. Inhibition of enzymes happens fairly quickly. So the bupropion would interfere with the action of this enzyme. So we could see those concentrations rise relatively quickly. I point that out because the aripiprazole Loraxil, so our long-acting injection, that may be a little bit problematic. So if those concentrations get higher, we might start to see some accumulation and additional toxicity in that patient population. Whereas for most of the others, I guess haloperidol being the exception, we'd be able to potentially make pretty quick dose adjustments to get rid of those adverse effects. So just something we'll need to be mindful of. The other interactions that have been reported of concern for bupropion are the reduction in seizure activity. So there are several classes of medications that can lower the seizure threshold. Bupropion tends to be one of them. So for doses that are recommended for tobacco cessation up to 300 milligrams, we don't see the highest risk. If you go up to 450, we could see a further increased risk of lowering the seizure threshold. But when it's used in combination with other agents, some antibiotics, our antidepressants lower the seizure threshold. Most of the antipsychotics do, stimulants. there is the potential that a patient may end up having some seizure activity. So just being mindful if they have a history of any type of seizure, that we are being intentional in monitoring for that. The other pharmacodynamic interaction that has been identified is they do see an increase in adverse effects when it's used in combination with other medications that have CNS depressant activity. So things like alcohol, a number of sedatives, anticholinergic medications, so that we tend to see much more of an effect, more of a synergistic effect than what we would have anticipated. So what can we do about that? Well, for the 2D6 substrates, being mindful that they may have increased concentrations, we may need to look at some dose alteration. So lowering the dose for at least the period of time that the patient's going to be on the bupropion. And then therapy modification if necessary or if appropriate. So I added the if appropriate. If you look at a number of those medications, so there were some beta blockers that were on there, some antipsychotic medications, some of our antidepressants, atomoxetine. It's possible that the patient responds really well to risperidone. In that case, it may not make sense to swap them off of risperidone for the 12, 24, 52 weeks that they're going to be on bupropion to transition off of tobacco products. So really kind of being mindful, is there a way to just lower the dose and manage those adverse effects as opposed to disrupting their more chronic regimen for something that's going to be a little bit more short term. But that may be something that has to be on the table in the event that they're motivated to do this. They don't want to give that up, but they are experiencing adverse effects. For the seizure threshold reduction, so monitoring, making sure education is provided to patients as well as their families or caregivers, friends that may be around to assist with monitoring, and then evaluating for lowest effective dose. So potentially looking, especially if patients are on higher doses of antidepressants, antipsychotic medications, stimulant medications, do we still need them on that high dose? Would it be possible to reduce the dose and still maintain that efficacy, but reduce the potential for exacerbating this and reducing the seizure threshold? It is recognized that many of the cases where this has occurred, there may have been other extenuating circumstances, extreme stress, illness, dehydration, sleep deprivation, ingestion of other substances. So it may not happen alone, but for more of an at-risk patient population, just something to be mindful of. And then the synergistic adverse effects. So letting patients know that they may see some additional adverse effects, again, trying to look for lowest effective dose. So from a management perspective, really just there is a potential to do some proactive screening to look at what the med list looks like and be able to identify if there may be a concern and potentially lowering some doses to prevent the patient from experiencing any type of detrimental adverse effects. How about for our nicotine replacement products? So we've got a bunch of different options. I did lump them in together because for the most part, they really are categorized together. So this includes the gum, the inhaler, our lozenge, nasal spray, as well as the patch. So dosing is going to depend on what it is that, how often they're smoking, how much they're smoking, what their symptoms look like. And for the most part, on a kinetic standpoint, we see a pretty significant difference based on the formulation that they're using. So with the inhaler, we can get a little bit lower bioavailability. We see the best bioavailability with our patches, followed by the intranasal spray, and then with our gum and our lozenge, as long as they're using the gum appropriately. Protein binding isn't a huge problem, so the nicotine gets to where we want it to be. But again, we see quite a bit of hepatic metabolism. So there is the potential for some adverse or for some pharmacokinetic interactions with inhibitors and inducers. But what we'll see is based on a lot of the dosing, especially I'm looking at things like the gum and the lozenge, you can take them relatively frequently. So up to 24 per day. So you'd be able to adjust and increase or decrease based on whether or not you're having more of an effect from it, or if you find that it's not lasting quite as long and you need it a little bit more frequently. Which is why they don't show up here. That was kind of my teaser for we don't see, documented issues related to that with inducers or inhibitors. There are quite a few that can impact the activity of those enzymes that process nicotine replacement products, but it doesn't seem to impact the overall efficacy or the tolerability of these. Maybe it's because they are used relatively short term. They can be used a little bit longer than the 12 weeks, but we don't see, even though they are processed through the cytochrome P450 system, established interactions. What we can see, so for agents that we're using orally, the lozenge as well as the gum, if patients are ingesting acidic food or beverages, it can reduce the absorption. So that may result in it being less effective for them. The other two main interactions, so adenosine, we can see increase in tachycardia. In varenicline, we can see increase in adverse effects. The other two products, the cerdoperin is actually a low molecular weight heparin, so it may diminish anticoagulant effects. It is not available in the United States, but I left it on there because it's kind of unique that it may impact the efficacy of a low molecular weight heparin. There are no reports of nicotine replacement products doing that to any other low molecular weight heparin. So for completeness sake, I did include that there. And then the methosurgide. So this is an agent that has been used. It's an ergotamine. It was used for migraine treatment. You could see increased vasoconstriction, increased blood pressure, increased heart rate. Could be problematic in some patients who may be at risk for cardiovascular disease. It's no longer routinely available in the United States, although there may be people who had prescriptions and still have that around. So I did, just for historical purposes, leave that on board. So from a management perspective, not a whole lot related to those nicotine replacement products, which is kind of nice. So avoiding acidic beverages or food at least 15 minutes prior to use of the gum or the lozenge. So this would include things like citrus, tomato-based products, soda, some dairy products. So yogurt, cheese, milk, all have been associated with reducing the concentrations of nicotine. Red wine, strong vinegar-based meals, apple juice, and sports drinks all have been associated with decreased efficacy. So if it's possible for at least 15 minutes before they are going to use one of those products, to not have them eat or drink would really be best. Water would be fine, but that'll just ensure that they get the maximum absorption that they can. For those other adverse effects, so we do see the potential for increased adverse effects with varenicline. If patients are on adenosine, kind of watching cardiovascular status would be helpful. Encourage the lowest effective dose, but for the most part, we don't necessarily see a ton of need for dose adjustments when patients are using these products. And to be fair, they do tend to use them for a short period of time. So this tends to be more of a transient treatment. So last one in our category is the varenicline. So similarly, initiating therapy at least a week. It could be longer. They don't have to have the quit date on day 8. It can be past day 8 if they need it to be. There is the titration, the dose titration when patients are starting it, really more for tolerability reasons, so that patients get used to those adverse effects and they can build up the effects build up some tolerance to those effects in their system. Maintenance therapy, so we're looking at least 11 weeks, but again, maybe more of a short-term treatment. On the pharmacokinetic side, we do not have any of the hepatic enzymes. So usually when I do drug interaction talks, a lot of them are related to inducers that are inhibitors, but really other than bupropion, that's not an issue. Varenicline is primarily removed using the organic cation transporter. So it's a protein in the kidneys that just essentially pumps out the varenicline. So it can be renally eliminated. So it shouldn't be a surprise that our drug interaction list is pretty lean. we're looking at adverse effects. So alcohol may enhance some of the adverse effects. They do recommend avoiding concomitant use if at all possible. And then the use of nicotine. So as we saw, varenicline popped up on the nicotine replacement products. So this is kind of the reciprocal. We can see those enhanced adverse effects when we are using combination therapy. So encouraging the lowest effective dose. If patients are experiencing adverse effects, we could try to back off, but for the most part, education and making sure that they're aware that that could happen tends to be the best intervention. So in summary, we've got a handful of products to be able to assist with tobacco cessation attempts. There are some interactions that may be problematic. So from a tolerability perspective, making sure we have that comprehensive list so we can screen for it, we should be able to avoid that relatively in most of the patients relatively well, so that they be able to use these products at least short term to be able to transition them off of whatever nicotine products that they're using. So that's what I got for drug interactions this morning, and I will